my boobs, and other things to distract her.
That started already.
I'm like bending over wearing like a shirt.
And she's talking about again. You're talking about while streaming.
Alright, Andy.
My stuff. That's streaming live to the rural kids.
Is it?
Yeah.
Hello! Well, they can if they want.
What's your password?
It's let's just broadcast it. Do you want my NetBank details as well? Just
You can do that.
It's working.
A lot of people watching it.
Yeah.
And people watching it.
This is a shout out to Tessoon. I think it's better to put it in
Just
now.
pause it for like 5 minutes and then it's like
Oh yeah.
this is like soon. Because it'll keep trying to catch up with you.
I reckon when it starts, we can try putting it at 5 in. You reckon?
We'd have to move the music
No, it's just one.
with how it wants to be. Great.
This looks dangerous. That's why I'm putting sticks around it. I need to stick some. And we need people to take photos. So just like I didn't bring my phone. Are you playing it? Is it better? I'll message chat and ask it.
Yeah, see what he thinks.
I got a new job. What is it? I got to take pictures. Use our camera. Is that a camera? No? Use your phone. Yes, I'm in it. That's right here. Got to sit. Yeah, we'll sit over there. And my chair that you sit? Yeah. No one will sit there, don't worry. What if we outsource it with a lower quality?
I think it's fine. What does Kat say?
Kat's saying it's still lagging a bit. What does Lucy say? Ask her how it is. Because if it might be because we're using uni wireless. We can ask.
Tell him to go into the Cog Wheel and go quality down to like 244.
Is it working?
Hello. I'm a type officer.
So you just like different types of stuff. Like
I'm also doing the live so people can see the screen of the one. Just like
Hi everybody, so hi, welcome. Hospital level, so I don't know if you don't know what a HMO is, if you don't know what basic physicians training is, I think I might have said that wrong. So it just shows that I don't know all these answers to these questions, and this is what we have to answer tonight. So I'll first give you a quick rundown of what we're going to cover, who's going to be speaking tonight. So our first speaker is Dr. Yogesh, who's here to talk about physicians training. So he's very graciously offered to volunteer his time tonight. Then we've got Dr. Julian Maingard, who's going to come in here and talk about the hospital levels and hospital structure. Then we've got our GP training pathway from Dr. Paul Treasure. And finally,
tonight, we love coming along to these things and sponsoring. Just a little bit of background of what Investec does. We are a specialist bank, so we are a bank. We can assist with all of your financial needs. So we have things like deposit facilities, credit cards, car finance, home loans. The difference with us is we do things that are very out of the ordinary. We can give you up to 100% finance for your first really drunk on Saturday night, and you're like, I don't want to pay $2.50. Anyway, so with our card, you can actually go to any of the major ATMs 5 times for free. So you don't have to worry about trying to find your bank's ATM. We also have no account keeping fees, so no $4 a month for them to just take your money. As soon as you start working, they'll start charging the fee. They won't be charging it now. The main thing I want to talk to you about is our Investec student offer. Our student offer allows you to open an overdraft account of up to $10,000 if you're in your final year and $6,000 in your penultimate. It also allows you to have an Investec credit card, which has Qantas-free compliant points. With the credit card, we give you a $6,000 limit. No repayments need to be made until 6 months after you graduate, and there is no annual fee on the card until such time that you start working. Now, if you join the AMA at the moment, it gives you 3 years free on the credit card. So let's just say it's free.
Yeah, and talk to you about a quick bit about physicians training.
Can you hear me? Okay. So, good evening, guys. My name is Yogesh. After graduating with internship, that's your first year now, and basic physician training will go along for 3 years basically. So you're on PPT 1 in your second year, PPT 2, PPT 3. And you usually sit for exams in your third year of training. After that, you enter your advanced training, and that's specialty dependent on how long it takes to finish. But it's usually around 3 years. Following that, you become a fellow or a consultant. That depends on if there is any job available. So my pathway so far, I came through the Austin Northern Bendigo Medical School. They were all together at the time. Now they're all separated. I graduated in 2008. I stayed with the Austin and the Northern, and I completed my internship in 2009. passed my exams last year, 2013, and now I'm into advanced training in general medicine. That's my senior medical registrar role, and hoping to get into nephrology next year, hopefully. So what rotations I have done so far? So 2009, as part of my internship. For internship, you need to do 3 core rotations, which are Gen Med, Gen Surg, and ED. And then you can do 2 other turn, basically, depending on what you want to do. So I did vascular surg, and I did another Gen Med, Gen Medical. From internship, I knew I wanted to do physician. So my second year out was what we call DPT 1 year. So as you can see, there's a lot of specialty rotations there. So I did oncology, renal, and did rehabilitation. So basically, if you want to do physician in your second year, you can put your preferences into what specialties you want to do. And further on BPT2, that's a mixed year where you're a registrar as well as you're a junior registrar as well as a resident. I think someone later will talk to you about what's the difference between a registrar and resident if you don't know. But basically, for my BPT2, I did gastro, and I did my first gen med rotation actually in abortion, which is, looking back into it, quite hard being in a different setting, in a different hospital. And then I did neurology term at the Austin and more gen med at the Northern. In 2012 was my BPT3 year, and that's mainly a registrar job. So you're in charge of a gen med unit, and you see patients that are admitted for simple stuff like exacerbation of COPD or CCF, for example. And you do a lot of reading term. It's only BPT3 that you are allowed to sit your exams. BPT3, sorry, that you are allowed to sit your exams. I did my written in 2012, but then I took a bit longer to do my clinical, which I did in 2013, during my, as you can see, BPT3 plus year. But I didn't work for 12 months, I worked only for 6 months. So I basically shared with another colleague. It's pretty sweet. The way we divided it was 5 weeks on, 5 weeks off. So for every term I had 5 weeks off. That allowed me to study as well. And I'll tell you why you need to study. So now, I'm the senior medical registrar at the Northern. So basically, I'm into advanced training. So I'm training to both gen med and nephrology. So in my second term, I'll be doing nephrology again at the Northern. And subsequently, hopefully, continue to nephrology. So the senior med-reg job that I'm doing at the moment, I do a lot of administrative work involving education for medical students as well as training basic physician trainees now. I'm involved with the structure of medical units, so I oversee all the medical units. I'm also involved in a lot of meetings, quality and safety, etc. So my clinical work is not that big at the moment. I do occasionally still admit people. I do clinics 2 or 3 times a week in renal. So this is your roadmap. You can't see anything there, but so this is where you are at the moment. Well, you will be after you finish your medical school. And for 3 years you will be this basic training if you want to do physician. And then you can specialize into advanced training. As you can see, there's quite a lot of different specialties that you can choose from. I won't go into this bit, it's a bit more complicated, but most people follow this pathway. So get into basic training and then into advanced training. So how do you get into basic physician training? Basically, everyone can get into basic physician training. There's no exam to get into, and most people, well, it used to be that most people will get in straight after internship. But now there are more and more interns and less positions. So not everyone will get a position into physician training. So how can you improve your chances? Well, very simple, being a good intern. So what I mean by that, being responsible, being accountable for your work, show interest in what you want to do. So from very early on, talk to the right people. The right people are me, senior medical registrar, and I'm choosing people for next year, people who want to do physician training. Director of physician education. So they are people that are appointed by the College of Physician. Each hospital has their own DPEs, and they are basically responsible for your physician education. You can also talk to your ward consultant, basically just to show interest in something that you want to do in the future. Participate in presentations, audit always helps. You can tee up some sort of research in your next year. I mean, as an intern, you won't get any chance to do research because you'll be so busy. And further on, in BPT2, BPT3, you won't again have the opportunity to do research because you'll be studying for your exams. So basically, the BPT1 is your sort of only year where you can do some research if you wanted to. Your previous research will count as well. In your MP4, you do 6 months of research. Is that correct? Yeah, so that can help as well. And getting good referees, basically, while you work on the ward as an intern, will help you get into BPT. So everyone can get into BPT, but some people will miss out because there are not that many positions compared to applicants. It doesn't matter. In the long run, you will get in the next year. It just means that you will take you a bit longer to get where you want to be. And in the big picture, it doesn't really matter. I won't go into too much detail, but basically you need to meet certain requirements every year in your basic physician training. As you will know, I think the mini CEX is already in place for medical students. So it's just a continuation of these requirements that you do every year. So you need to do 4 of those mini CEX, you need to get a progress report, you need to get a board consultant report. But once you are into the training, we will guide you on and meeting your requirement. Fees, important. As you can see, to be a BPT, you need to pay 3,300 a year. So for 3 years, that's about close to 10 grand. Plus your examination fees, written exam are the 1,500, clinical exam are the 2,500. Plus you go to courses to help with your training, that's another 1,200. So you'll be forking out about 12 to 15 grand by the time you enter advanced training. Don't ask me where this money goes. Again, by the end of your training, again, I wouldn't talk too much about that because the hospital should help you. The hospital that you will go to should help you to get all those requirements to make sure that you get into advanced training. As I said, not everyone will get to do it in 3 years. Some of you might take longer. And before you start your advanced training, you need to complete both the written and clinical examination. Now, for a lot of people, that's the major deterrent to the physician is the exam. It's a pretty hard exam. You need to study for about 18 months.
Harder than GAMSAT.
So maybe 12 months if you're good. So you will be taking your written exam in your third year. So as from your PPT2, so your second year, you need to start studying basically. And so people that are going to take exam in February of next year have started studying since April. So it's a long year sort of process. And when you pass the written, then comes the clinical, which people that pass the exam this year are preparing now, and the exams in late July and early August. So that's the clinical exam. So basically, for about 15 to 18 months, you need to put a lot of effort and sacrifices to get through. But that's all done through consortium. Like each different hospital has their own consortium. So I trained with the Central Northwest consortium, which comprises Northern and Austin. It's a very well organized and structured sort of organization. We do understand that this is a difficult time, and we provide as much support as we can. And this consortium really train you to pass, basically. So they have a lot of lectures. At the moment, we're preparing for the clinical exam. We take people to do cases, long cases, short cases. And the exam and the success rate is usually pretty good. Each hospital will have its own consortium, basically. They don't come at the cost of having the right work-life balance. And especially when you're studying, it's very hard. You need to make sure that you've got good support around you, friends, both medical and non-medical friends. You don't want to be talking medical stuff all the time. But it's good to have good medical friends to debrief as well. It can get quite overwhelming sometimes, especially when you're in intern. Do other things, keep an interest in whatever you want, sports, music, reading, writing, socializing. I didn't put alcohol there, but in moderation. Always take full advantage of your holidays. You will have about 5 weeks a year for holidays. Make sure you make the most of them. It's also important to look after yourself. And a lot of doctors neglect their own health because they are so caught up in achieving to get where they want quickly. Why did I do physician training? I think provide a holistic approach to a patient's care. As you can see, it's very diverse and varied. You can specialize in a lot of different specialties. I still find it very stimulating. There are always diagnostic dilemmas still. It's very challenging, but most of it I get a lot of joy satisfaction with what I do. Why not? It is stressful. As I said, the exam period can be quite frustrating and stressful. And when you compare with your surgical colleagues, I guess you'll be earning less than them. For some people, that might be an important factor. Well, that's all I had today to give you an overview of physician training, but I'm happy to take the questions.
What's the pass rate for exams?
It varies from hospital to hospital, from consortium to consortium. The Austin Northern this year had a pass rate for the written exam of 88%. Last year, the clinical pass rate was 92%. So people do pass. Yes?
Do you get like a list of things you need to know? Or?
Yes. So with the written exam, You have lectures through the college weekly, so they give you a bit of a structure about what to study. The questions might not necessarily come from there, but you do have a sort of a structure. With the clinical, it's a bit different. It depends. So with the clinical exam, the way it works is you have to go interstate to a different hospital to do your clinical exam. So there are short cases and long cases. So short cases are usually 15 minutes, 7 minutes to examine and 7 minutes to present. And they're usually things that you've never seen before. But people pass, and your long cases are, you spend an hour with a patient and present for about it. You present for about 12, 13 minutes and you get questions for another 12, 13 minutes. That's basically the exam, the clinical exam.
First 3 years, you're doing the basic physician's training, paying $2,000 for training in a year.
Yeah.
Do you still get paid whilst doing that?
Yeah, you're working, so you're earning an income. Yeah. So that's probably maybe 3 weeks worth of working. It's not too bad. Yeah.
What are the differences between basic physician training for adults versus teens? And is it possible to switch after 1 year?
No, it's different. So you either do adults or pediatrics. So if you've done 2 years of adults and you want to go to pediatrics, you need to start back from the start. What's the difference? It's similar except that the pediatric is for kids. But it's basically the same sort of format. Yeah. Is there anyone talking about pediatrics?
Not tonight, but hopefully next Careers Night, which will be coming up next semester, we'll have pediatrics and some of the other specialties.
I think it's more difficult, pediatrics. That's my personal opinion. Yeah.
What happens if you fail a written or clinical exam?
Yeah, so you can have 5 attempts at the written, and I think 3 to 5 attempts at the clinical as well. But you don't want to be spending 10 years just trying to get the exams. But it doesn't, in the big picture, it really doesn't matter if you fail the first time, because most likely you will pass the second time. And it's just a year back. And during that time, you're getting more experience on the wards and you're actually a better doctor with that extra year. Yeah.
If you're going to do it all over again, do you think you would be able to pass the exam without taking time off work?
Absolutely. Most people don't take time off work. I just wanted a bit of a break, so that's why I took a bit of time off. Yeah.
Could you explain a little more the BPT3 plus
Yeah, so the BPT3 plus doesn't really exist. So the BPT3 is where most people will take their exams. The BPT plus come into effect if you didn't get through your BPT3, so that then you have to continue with the medical regime or whatever, so that's called BPT3 plus. Or if you didn't want to sit your exam in your 30, you wanted to defer it for 1 year, then that's where it comes into effect. So I didn't take my clinical in that year, so I took it the year after. So that's all.
So in the BPT3 year, what was the 6 months? You did focus on
That's the last year, yeah.
So you can appreciate time with that.
Well, not every hospital will offer that, and again, it depends on which hospital you're working at. Most hospitals might not offer it because, again, of the sheer number of trainings. But it's something that you might consider. Or you might take a whole year off and come back and do it. That's still feasible. Yeah.
Is there often a time between passing your BPT exam and leaving to degree and then getting into an advanced training program?
Yeah, that's a good question. It's getting harder and harder to get into advanced training, just like it's getting harder and harder to get internship positions. So sometimes the way to get into advanced training, once you pass the exam, that's your passport to get into advanced training. But then you have to go through a selection process all over again. What they look at is, again, basic things that I talk about: interest, your CV, your referees. And again, there are more applicants into some specialties. Popular ones are cardiology, gastroenterology. They're always very popular. So some people might not get in the first time. What do they do with that year? They might just do a whole year of research to improve their CVs. Oh, they might do the job that I'm doing at the moment, the senior medical registrar job. So just buy some time to get into advanced training. But yeah, there can be a few people that will not get into advanced training as well.
So I'll probably just have one more question. I think you have the end of the one answer.
For those of us who want to do a bit of research, you mentioned that it's a good time to do it in BPT 1.
Yeah.
If you want to do a couple of years of research, is it possible to stretch that out?
Look, it's not an absolute limit. You can't do it in your BPT 2. It just is going to be a bit hard. It's going to be a full-on year studying, doing research as well. I mean, you can stretch it out, or you can sort of defer for a bit, just do research and take the exams in the BPT 4. But it just means you pay $3,000 extra for one extra year, so that's fine.
All right, could everyone give a big thank you to Dr. Next we've got another one of our sponsors to give us a quick talk. So I'm going to welcome Bonjour. I'd like to say a big hello to our rural students. So, hi rural students, hope you can hear me and sound working.
Alright, thanks. Thank you everyone. Thank you everyone. Just quickly, both Ben and I are from the Bongiorno groups. My name's Rick and this is Ben Bongiorno. The Bongiorno group have been specialising in providing medical professionals with accounting and financial planning advice for 50 years. Okay, so today's a very good day for us to actually be here because this week, hand up if you're in final year. Yeah, most of us in here. So this week on Thursday, we've actually got a in-house session at the Bongiorno group where we've invited the Chief Medical Officer from the Austin Hospital to come in to our office and explain to final years and those looking to go to Austin or any hospital what they look for in applications. So you're in the business doing your applications now, or most of you. And so we don't do this by just us knowing the Chief Medical Officer or anything else like that. These guys approach us and say, look, we know you guys work with medical professionals and we want to help as well. So Nero, where's Nero? Nero's up the back here. Nero's got a form. Now, if you want invitations to these sorts of events or more information about anything that you see up on the board here, fill one of these forms out. There's an opt-in box, which is a marketing thing. You have to tick that if you want us to send you an email or invitation. But we're also giving away a couple of movie tickets tonight, so they're Gold Pass tickets if you want to put those into. So, firstly, tax. Now, we've just heard that the first year at BBC will be costing around about $15,000. That is fully tax deductible, by the way. So, you can claim that on a tax return. So, do not feel that it is entirely lost. You spending that money, and seeing one of us will be able to tell you exactly how to get paid for it too. Some of it you can actually claim through help or a X line, so that's a really good way to do it. Salary packaging is a great way to reduce your tax as well. So, moving on from there, finance. Already heard Chrissy from Investec talk about banking and loans and those sorts of things. We won't go into that in too much detail. We've got a bank branch in our office for the sole use of our clients. So that enabled Ben and I to both buy our own houses over the last couple of years, which has been fantastic for us as well.
Now you will have seen a picture of Australia just before. It just outlines that Bongiorno's has a national network. So we're here to help medical practitioners across the whole of Australia. And that is our own clientele, both Ricky and myself and the advisors of the Bongiorno group. So, it gives us huge scope to give tailor-made sort of advice just to medical practitioners. And like Ricky just said, with the finance industry. Now, the other area that we're able to help you is with the insurance area. And what we're speaking about there is making sure that we protect you. And we always have a plan B if anything is to go wrong with your own ability to be the best doctor you can possibly be, as well as protecting your assets into the future. And the other area that we are here to advise and give assistance with is your financial planning. And I think really nicely, simply put, is that it's here to align your goals with what you want to do regarding your own finances. So if you want to travel, if you want to buy a house, like Ricky just mentioned, if you prefer to, invest in a portfolio of assets, being shares, whatever it is. But that's the thing, we're here to help with all of these different major areas, being your finance, your insurance, your financial planning, and your tax. And it's just for medical practitioners. Now, up on the board, you'll see the internship offer, and we understand we're here speaking with students. So what we'd like to outline is that we are able to provide you with a free tax return while you're a student. Now, Ricky and myself, we spoke here about 3 weeks ago or thereabouts, and we're speaking about a student loan offer. So that's an unsecured $10,000 loan for you in your final and penultimate years to give you the opportunity to go on an elective, pay your parents back, pay a credit card back. And again, you won't see those sort of options out there just due to the fact that we're here to specialise with you guys being doctors. Now, you'll receive ongoing support from myself and Ricky. And, if you are working right now, please come in and make a time with us. Ricky just mentioned before that we have the Chief Medical Officer of the Austin Hospital coming to the Bongiorno group to really give you guys an added advantage when, starting your internship and being the best doctor that you can possibly be, such as people like Julian and the doctor we just heard from. Now, that's normally valued at nearly $300. Sorry, I've forgotten that guy's name. I'm really sorry. Sorry, what was your name? Sorry. BP training, apparently it costs a fair bit of money. Now, again, just to recap on our services, we're here to help you with your tax, your insurance, your financial planning, and your finance. There are our names and numbers, and if you do have any questions, we'll be out there later. We're here tonight to give out 2 complimentary Gold Class tickets, as well as a $30 food voucher. So feel free to put your name down, but please, again, if you've got any questions, let us know. And thank you very much for having us.
Sure, everyone will come and have a quick chat to you before we during the break. So up next, we've got one of our amazing medical residents from RMH, I believe, who's come here to tell us a bit about hospital levels, intern, what you do as intern, what you do as a resident. So if everyone could put their hands together for Dr. Julian Mangard.
Thanks everyone. So my name's Julian, I'm one of the residents over at Foster Road at Royal Melbourne Hospital, and I think it's probably a good idea to give you guys a bit of perspective because I'm still quite junior. It's my second year out of university, so I still remember sitting in the chairs when you're sitting there and doing my lectures. I applied for a medical year this year. It sort of changed my mind. I'm a bit of a mixed year. So I think I just want to reiterate to all of you that there's no great rush. You get a lot of pressure to stream off into certain specialties or a certain interest area that you have. But there's no, while you feel that there is a rush, I don't think there's a huge rush. I think you can take your time. If you're not sure, I wouldn't stress too much. Can I just get a show of hands of what year level you guys are at? So we get first year. lots. You guys are usually the most keen to get some more about your career. And Rob and Arthur will get how much I'll win when I'm second year, couple, third years, and then fourth year's final year, wasn't it? So fourth years. Okay, alright. So I did my internship last year. I suppose I'll tell you about the process of how I got, through internship, through my residency, and then I'll go a bit I'll talk a little bit about the role of an intern, the role of a resident, and then moving forward, becoming a registrar and onwards, which I can't tell you much about, but I'll tell you what the differences are in my mind. So for the final years coming up, you've got applications happening soon, is that right? In a month or so. So they're pretty stressful. They're very competitive, and you'll all have to go through it. It's all through PMCB. I'm sure all the final years know already because they're opening now or opening soon. And you essentially you pick what hospitals you want to go to. You rank them in order on a computer system on the computer online, and then you apply individually for all those hospitals and recommend exchange. Then you interview at all these hospitals that you want to go to, and those hospitals will then say yes, we'll take you, and they rank all their applicants in order, and the computer match does some crazy algorithm. I have no idea how it works, and then you end up at a hospital somewhere. So that's what I did just over a year ago, and you'll all have to go through it at some point. Then you move forward into the internship, and it's your first day as a doctor, and everything you learn at medical school, you can't remember a thing. You don't remember a single thing. People ask you, can we change this? Can we change that? I don't remember, I don't know, what does that drug even do? I don't even know. Can you sign this? Sure, I'll sign that. Signing all these forms, you have no idea what's going on. And it's pretty stressful. It's really stressful. And as everyone knows, your intern year is a sort of provisional year, provisionally registered, so provisional year, so you're highly supervised when you're supposed to be, and that's not always the case, but it's supposed to be a highly supervised, highly controlled environment that you guys work in, and it's a very steep learning curve. Okay, so I'll tell you a bit about my year and what I did. So I started up in the stroke unit at Royal Melbourne, and day one I walked in, I thought I'll do a bit of paperwork early, I'll get my head around everything, I'll start early. I got in there at 7:15, sat in the doctor's office, which unfortunately doesn't have a door, and the nurse runs up to me and says, oh, this guy's got a facial droop, and he wasn't there before, and anyway, so the guy was having a stroke, and it was my first day of internship, there was nobody else around, it was a night code person, I didn't know how to contact them, so the paging system worked, and I had my registrar's number, but his phone was off, so he was probably still asleep, to be honest. And just lucky for me, they were quite supportive. The consultant was already in his office doing some work, so he came around and sorted out. But that's the sort of stuff you'll have to expect when you first start. It's very steep learning curve. You'll jump straight into the deep end. And I did that for 10 weeks, so the 10-week rotations, you do 5 of them. Then I jumped into what I do next. I did patellar surgery. Water run goes at 100 miles an hour, there's like 40 patients, you're dropping folders everywhere, people laughing at you, you don't know where your pen's gone, you're annoyed, registrar walks way too fast, don't hear what he says, and you write down the wrong things on the water run, so your job's very important because those who are more senior than you, the registrars, they will tell you a plan, but you're documenting the plan. If you document the wrong thing, mistakes happen. Okay, so on my third day on surgery, I think I wrote somebody can eat after they had some gastric surgery. That's a bad idea. But luckily the consultant picked up on it early. Patient didn't eat, but that's the kind of stuff you need to be aware of. A lot of the jobs seem quite mundane and boring, but they're quite important. After that, I did general medicine, which you all have to do, which as an intern is long hours. So they roster you from 8 to 4:30. You're there from 7 in the morning till 7 or 8 o'clock at night. That includes the registrar sometimes. You end up doing ward rounds at 7 o'clock in the evening. It's a very, very stressful time, but again, lots of learning, lots of support. After that, I did emergency, which again, everyone has to do. It's like a national, every intern has to do some general medicine and some surgical rotation and some emergency. Emergency at Royal Melbourne, again, very good. Saw lots, learned lots. It's very busy. And then my last rotation was Horsham, and that was, I believe, the most interesting of all my rotations. So I spent 13 weeks out in Horsham. And if you're lucky, you'll get it as your last rotation when you've had a year of learning and you're on top of all the basics. If you're unlucky, it's your first rotation and it's you're on a night shift and the registrar calls in sick. And it's just you in an emergency department, which is like the feeder hospital for all the country towns around. And so you see lots of stuff there. The only time I've done CPR last year, 4 times, was in Horsham. You manage children, which you're right, children are hard, they're scary. And I used to avoid them when they came into the ED department because I sort of crammed my pediatric term and didn't remember a whole lot. So the Royal Children's Guidelines, just for the tip for the future, is where you need to go for pediatrics. So again, that was a very steep learning curve, and you often find yourself in an emergency department completely on your own. And that's the sort of place where trauma will come, particularly if the helicopter can't get there because of bad weather. A few traumas come in, and the registrar was doing a ward round on the ward round, and it was just me and 3 nurses. And obviously the nursing staff are very experienced. So I guess another tip for when you're a junior medical officer is that you need to rely on the staff around you sometimes because they've been doing it for many years. And they'll often know a lot, so don't be afraid to ask for help because it's all about patient safety at the end of the day. But traumas, heart attacks, strokes, they all come into these country towns and you have to fly them to Melbourne. It's all very stressful. But that's a sort of rough idea of what you can expect in your intern year, depending on where you go. It's mostly supported, but sometimes you will find yourself on your own and you will find yourself occasionally having to make decisions on your own. Keeping in mind that sometimes you can always make a phone call to someone more senior to run it by them. You should never feel like you can't call for help. That's an important point. After that year, I was sort of umming and ahhing about what I wanted to do. I enjoyed my stroke term a lot, so I was like, I want to do neurology, I'm not sure. I also enjoy medical imaging a fair bit, I'm not sure I want to do radiology. I get quite excited when I see chest x-rays that are normal. That's me. So I applied for a medical year, and I thought, if I'm going to do maybe neurology or radiology, maybe I should do some neurosurgery to supplement that. So depending on what hospital you go to, in your second year, some hospitals, they have dedicated rotations. You do cardiology, you do gastroenterology, you do whatever. At Royal Melbourne, they've got a relieving term where you essentially, over 13 weeks, you do 2 weeks of medical oncology, 2 weeks of gastro, 3 weeks of cardiology, and you take over from people who are going on leave or exam leave or on holiday. So that's what I did for my first term. I did 3 weeks of medical oncology, and again, this is where it's another steep learning curve. We cover 9 medical units overnight, so it's just you. And that's probably 100 plus patients at Royal Melbourne. Fairly sure it's pretty unsafe, but that's what they do. So you need to be aware that that's what will happen in the future. There are lots of very sick patients, and at night time, everything seems to go wrong at night. I don't know why. But that's what I did my first time. And I said, I think I should do some neurosurgery. So I did 5 weeks of neurosurgery at Royal Melbourne. Again, very steep learning curve, but you learn a lot when you come out at the end much better for it. Now on to my neurology term, which I'm enjoying a fair bit. I suppose the point I'm trying to make with this is I'm still a bit confused about what I want to do. And don't rush. So I initially was like, yep, I'll do the BPT 1 year, I'll do a medical year. And then I said, I don't have any money, so we're on holiday. I don't want to pay $3,000, so I'll just mix it up a bit, do some neurosurgery, do some neurology, do cardiology next. At the end of the year, I'm doing plastic surgery. I think I might apply for radiology next month. It's on PMTV this year as well. But if I don't, I'll just decide again later in the end of the year what I want to do. I don't think there's a huge, you get a lot of pressure from level 1, first year uni, all the way through in an internship. You're going to do medical year next year, a surgical year, you're going to do psychiatry, you're going to do pediatrics, you're going to do children, there's all these questions. And a lot of people do know what they want to do, and that's great. They stream off into the different areas. Some people are confused, they have no idea. Always someone like myself. I had a friend who, 6 years of medical school, or 4.5 years of medical school. All he wanted to do was general surgery. He joined the Surgical Student Society. It's all surgery, surgery, surgery. He did his surgical rotation, and he said, I hate this, it's the worst. I said, you want to go to theatre? And he's like, it's so boring, I don't want to go to theatre. I hate it. So many pre-admissions clinic. I'll see the patients, I'll work them up. Now he wants to do haematology. He's doing a BBT 1 year. So people will tell you, I want to do surgery, and I'll do surgery, and I'll say, this sucks. I hate it. Can't keep up with the ward round. Can't write notes. I can't even read my own handwriting. So yeah, don't rush. Okay, you can have a rough idea. If you know what you want to do, that's fantastic. If you really know what you want to do, getting started on research early is a good idea. I sort of fell into, I'm doing a research project, I fell into that research project. I was a student, and the registrar turned to me and said, you can research, and I said, sure thing, why not? It happened to be a sort of neuroimaging/neurology project at Royal Melbourne. So I started doing that as a student, and I also used that in my interview to say that's the reason why I want to come back here for internship. And that turned out really well, so I got a publication from that. I've had 2 publications from that, and my supervisor is doing another research project now. So if you are interested in something and you're keen on something, don't be afraid to email consultants or researchers around the place and ask for research projects. It's a lot of work going around. Supposed to add to the confusion about, do I want to do medicine or whatever, I'm doing the surgical diploma as well. So I sit here on Mondays and Thursdays, continue lectures as well. That costs $12,000. So it's unavoidable, these high costs. I don't know what they're using the money for, but again, more learning. You don't realise how much anatomy you forget when you go back and learn it again. But it's sometimes good to get a bit of perspective and the clinical experience to go out and learn it. I think you guys wanted me to talk about the difference between an intern and a resident and the registrar. It's a rough idea. So obviously as an intern, I said it's a very supportive environment. You're very junior. You're highly supervised. You need to run. You don't need to run all decisions by, but a lot of your decisions, if you're not sure, you run it by someone more senior. And I suppose that happens as a resident as well. You got your general medical registration, but I find this year generally there's a little bit more responsibility given to you. People trust you a little bit more. That just comes because you've had a year's worth of experience. You're expected to do admissions, so on urology or even on some of the surgical rotations when patients come to the hospital. The registrar often for ward admissions, for example, you go and see the patient first up, you do tech history, and you do your long case. You guys still do long cases? Yeah, so you do your long case, tech history, you do your examination, and you formulate a plan. Sometimes you're run by the reg, if you're not sure, just make your own plan and go with it. Someone will come and see the patient and then anyway on your around. You still take notes, so it's very, very similar to being an intern. You still take notes, you still do all the grunt work on the ward. But that just means sometimes you know patients better than other people. Definitely you have to solve the influence today and methodology. You get to do more procedures because people know you've done more procedures. So depending on what hospital you go to, some people will let you do. I have a friend of mine that's go for an orthopedic procedure the whole day and consult with them and do it from start to finish. So if you want to do surgery, that's some hospitals are better for that than others. On urology, for example, I get called lumbar punctures because everyone else is doing them, I think. So the registers are always there to back you up, but when the our patients come for lumbar punctures, their patient should be a resident, me, and I go and do all the lumbar punctures on the ward. So there's a few more procedures you get to do, have the experience, get to do admissions. Overnight, so I covered medical oncology and 9 other units overnight. Every patient that comes under one of those units overnight, it's been an emergency. The emergency physicians wake up the registrar at home at 3 in the morning, tell them the story, and the registrar says fine, put them on antibiotics and call the residents. You come down and see the patient. But at 3 in the morning, when everyone's tired, you need to double check that you're not missing anything because sometimes people are tired, they're rushed. So there's a fair bit of responsibility and you're not sure you call the registrar. You don't do much of that as an intern, quite in at the wrong open anyway. And then you've heard from Regis, and I think you'll hear a few more registrars later about streaming off into your specialty areas. And again, no rush. That all of you will have to pick an area at some point, whether it's general practice or physician's training or surgical training. And that's it. That's where I am now. I'm sure I have much else to say. So it's very stressful. You get to spend lots of money. I haven't seen my family much in 4 weeks. On neurosurgery, doing 130 hours a fortnight. rostered, so a lot of you will go through stuff like that. You also do 100 plus hours in gen med sometimes unrostered. You know, you do like 76 hours rostered and that's unrostered. That's just goes with the job. I'm sure a lot of you sort of knew about that when you started. I don't think you realised how stressful it is. Yeah. Does anyone have any questions? Sorry, I didn't have any slides. My markup told me I didn't bring any.
Yep. Do you still study a lot in your free time?
Yes, at the moment all I really do is go to work, go home and read lasts. You guys want last anatomy? I read lasts fall asleep in bed reading lasts because I got an exam in 2 weeks. So my research is on hold at the moment. It's too hard to do all those.
Any other questions? Yep.
When you apply for this year after intern, you do say I'd like to do a rotation in this, and this, and how much choice do you have?
Yeah, it's a good question. I went to my interview and said I'm pretty sure I still want to do neurology, but maybe also radiology. There's a big radiology department here. And Melbourne Brain Centre is attached to Royal Melbourne, so I use that in my interview. It's Melbourne Brain Centre. I've done research here. You guys offer this rotation to residents, and that's part of the reason why I want to come back here. Generally, I found at the Royal Melbourne it's a lot easier. Once you're in as an intern, they've got more resident positions than they do intern spots. And they end up with a lot of unmatched spots, which means they say, we want all these people, but 20 of those people go to the children's, they go to the Austin, they go into state, and they end up with 20 spots with no one to fill those positions. So you generally have a better chance of getting in somewhere, in some hospitals, if you've done your internship there. So it was my interview went for 2 minutes, and I knew about people and they said, hi, and they go, that's why do you want to come in? And I said, blah, 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 and then they said, fine. Next it depends on the hospital, it depends on how you go through it, I suppose. I think the Austin will be, I'm not sure about the Austin, I think they have less resident spots than intern spots, I'm not sure. Something along those lines, but not every place.
I think the hospital would try to give you your top preference.
Yeah.
They might not give you all your top 4 preference, but then they'll try to give you.
So they get you to rank your rotations. They give you 76 timetables at Royal Melbourne. They say these are the rotations you do in this order, and you pick them and you can swap with your colleagues. So my friend went to, I had a 2B announced at the end of the year. The choices were rehab, hospital in the home, vascular surgery, and plastics. And I didn't really want to do rehab or hospital in the home, so I said, I'll do vascular. Then my friend said, I really want to do vascular. He wants to do vascular surgery. He's applying for vascular surgery this year. So I swapped with him and I'm doing plastic surgery. And medical workforce places in most hospitals are happy to do that. That's what they do. Any other questions? Yep.
When you pick your rotation, do you pick based on what you think you want to go into afterwards, or what you think is kind of good for you in terms of learning for the training program?
Yeah, so I suppose it depends what you want to do. That's a good question. I picked my rotation based on what I thought were my interest areas. So I picked, last year I picked stroke, I picked vocabulary. I enjoyed those sorts of things in medical school, so I could first get some experience. I picked abortion, so I could do some anaesthetics there as well. And that was quite good. You get to do a lot of integration with using all the IV sedation to bring people off to sleep, and the consultants there let you do most of the work, they just stand there and watch you. And then for my resident year, I picked neurology and cardiology, the ones that I ranked as my top 2, because I thought, maybe do I want a career in cardiology or I'm obviously confused, but do I want a career in cardiology, do I want a career in neurology? I'll pick those 2 and whatever else I'll try and work out with those people. So that's how I picked mine.
So I think we'll leave it there for now. Could everyone give a big round of applause for Dr. Julian? Alright, one last thing before we go and have delicious pizza. We've just got Michaela from the bar to come here and talk to you a few things. So could everyone give a big round to Michaela?
Hi everyone, thanks for your time. I know you can smell the pizza wafting up towards you, so I'll be nice and quick. And hi to all the people who are streaming live from the rural areas. Great for you guys to join us as well. To start it off, I'm just going to break it up with a quick video, and then I'll let you guys know what offers we have for you today.
So as a student, you're still learning and it's really easy to make mistakes. That's why it's great that a manager helps you along the way. Plus, it's free.
As a student, you don't know what you don't know. Having expert advice can really reassure you. MBOs are medical defense organisations. They are your safety. They're the people in your corner when things go wrong. Doctors need to be a member of an MBO because there's potential in many legal issues they face every day. So the MLA hotline is a hotline which is available to me to be able to call up at any time if I have any medical legal issues for student members, in addition to medical indemnity insurance, to find out there's free travel insurance.
So one of the great things about Avant is you have opportunities you might not get elsewhere. Last year, one lucky student got the opportunity to go visit Fiji and have a placement with Interclass.
It provides an opportunity for students to have their voice heard within an event which is unique among MBOs in Australia.
So Avant has more than 11,000 medical student members, which means they're an important voice when representing the interests of students.
In my first year of uni, I received the Careers in Medicine handbook from Avant, and I found this an amazing resource.
As a member of Avant, you get a free electives book, and inside it contains lots of information about different electives around the world, which can really help you.
I really like being a member of Avant because it gives me the opportunity to be a part of ASAC, which allows me to network with other students and make a difference to my fellow kids.
Great. So as I held up today, we're giving away the Careers in Medicine guide. So it's a really fantastic resource. It's got a couple of pages on most of the specialties. So if you want to have a flick through, it helps you know how much sort of clinical contact time you might have versus how intellectually stimulating it may be, all those sort of things. So all you need to do is be a member. So just come up and have a chat with either myself, Michaela, or Michelle. We're able to hand this over. And just one other thing I wanted to let you know about, unfortunately it's actually happening right at this moment, but we're hosting a Careers in Medicine webinar. So it will, obviously it's live right now, but it's being recorded, so you guys can sort of log on to our website and watch that. And we've got registrars and consultants talking about ONG and also about surgery. So please feel free to jump online and watch that. And for all the people who are rural, please feel free to contact us and we'll send you out a book as well. So thanks everyone, enjoy the pizza.
So after the break, we've got Dr. Wallace Lau, and to talk to you about surgery and GP. Yeah, so I hope you all enjoy your pizza, and I'm going to go watch all the sponsors soon. Thank you. See you in about 15.
I'm not trying to have jokes. Yeah,
I used to be, so I just wanted to.
Yeah, seriously.
I got my own.
I'm too lazy and like I need to look after things and no, I just have people. No, I'm allowed to. I'm allowed to mention you.
Yes! Oh my god! Yeah.
Unbelievable show.
Yeah. Do you get me somewhere around there?
No.
Why are you so selfish? What the fuck? Unbelievable. So selfish.
Unbelievable.
I spent my Tic Tac with you. And I needed that Tic Tac.
What you did?
I did.
Remember how I diverged you the other day?
No. Oh yeah, I didn't have fun.
Must have been like God. I've noticed, yeah, that's a lot. Yeah. Because back in the
Oh my god, I love this girl. This
So we're probably about to start on the second subject. Alright, so just before we get started again, we're just going to announce the winner of the competition. So, please put your name in. And the winner of 2 gold class movie tickets is Kelvin. Short today is very yeah, okay, cool. Alright, so our next speaker is from RACDP, the Royal Australian College of General Practitioners. We've got the amazing Dr. Paul Tesher. And he's going to tell us a bit about general practice and all that involves. So, thank you, Paul.
Thank you everyone for inviting me here today. Can everyone hear me? No? Yes? So I'm going to be speaking for 15 to 20 minutes about general practice. And to give you a bit of background before I start, I'm a final year trainee to registrar in the college program. I graduated from Melbourne Uni in 2009 and then went on to Royal Melbourne, did 3 years of internship plus residency before settling on general practice. And I did a smattering of medical and general units, which I'll come back to about the merits of, what specifics to do if you're interested in general practice or, what paths you can take to get there. So what we'll cover today, why general practice and what's it all about, and then what are the specifics of the training program, from internship and beyond. So I understand that now most, if not all of you, have some idea of what general practice is because the training program tries to incorporate it. Whether or not that's successful, I'm not sure. But particularly for the final years, you should have had some idea by now. And while you may be considering general practice, you probably don't really understand what it's like to work as a GP compared to any other kind of doctor. I think that it's quite underestimated how prevalent GPs are compared to the average doctor. At least a third, if not a half, of all doctors end up becoming GPs. But it's not really represented well in medical school because most of your professors are the specialists, the physicians and surgeons. So keep in mind that general practice has a broad scope in the community and looks after every aspect that those specialists would also see. So why general practice? What's it all about? Well, there's a lot that attracted me and a lot of my colleagues to general practice that you don't necessarily get in other specialties. Now, I saw the physician representative mention variety. Yes, you get a bit of variety in physician training as long as you don't mind just looking after adults or only kids. You can't really get both. General practice you can. In general practice you don't just get men or women, you get everything. You get the full spectrum of illness from the very young to the very old, from the mental to the psychological to the physical. Sorry, mental and psychological are pretty similar. But you do get the whole of life care. You get from when people are born until when they're in their final days. You get a lot of flexibility, a lot more, I think, than the other training programs. You get flexibility when you're in the training program, you get flexibility once you finish. You get to choose a lot more about your working conditions rather than just what the hospital will reluctantly give you. You get to choose how long you train for. You could do it in as little as 3 years, or you could do it much longer if that suits you better. You could do it full-time or part-time, and any combination of that. And the lifestyle is really good. I'd like to highlight the photo here. What do you notice about this woman? She's smiling. She's happy. She enjoys her life. She might even have exams coming up, but that's okay because life is good for her. She gets to work as much or as little as she wants to, and she gets to do whatever else she wants to apart from that. So you get a great lifestyle in general practice, and that was one of the things in particular that drew me to it. And you can only appreciate once you start working as an intern and then a resident, is that when you're working overnight, when you're on call, when you're doing 14-hour shifts, life's not that great unless you really enjoy what you're doing there. And I really enjoy medicine, but I didn't enjoy those hours and that lifestyle. And it's very important to work out what drives you. If you're so interested in a particular specialty that you don't mind working all day, every day, great. If you don't mind studying for 12, 18 months, just working and studying for your Part 1 exams, or go for physician training. But if you want to still have a life and enjoy work, and enjoy studying for the exam, because it's not, back-breaking, then general practice might be for you. As I touched on, the training program is shorter than pretty much every specialty. You can do it in as little as 3 years, including a year of hospital work, which, as far as I'm aware, no other training program offers. Physician training is now 6 to 7 years. Likewise with a lot of other specialty trainings. So that's a big advantage. And it also offers a lot of opportunities. The physicians and surgeons will tell you, yes, you can do anything, but it's really, you can do one thing very well. If you want to do anything and change from one thing to another, it's much harder in a training program like physician or surgeon. But in general practice, you become a GP, a general practitioner, and then you can decide, hey, I really like skin stuff. I'm going to focus on that. Or I really like women's health. I'm just going to see women patients. And you can do all those things and many more. So the key qualities of general practice very much align with what are the benefits or key qualities of working in general practice. You get a person-centred attitude, which I think a lot of colleges now sort of like to say, yes, we're person-centred. But really, you're person-centred as much as your area of interest matters. So if you're the cardiologist, you're person-centred as long as the angina is affecting their ability to work. You're not really looking at the other things. Continuity of care. Again, the specialist will say, yes, I get to look after their hernia from before they see me to afterwards and every year after that, just a routine follow-up. But it's not really the same continuity that you'd get looking after someone's full range of medical problems for 30, 40 years if you wanted to. Whole person care and diagnostic and therapeutic skill. I think there's a lot of skill required to be a GP. And one of the traditional reasons general practice was sort of shunned amongst the specialists was because many years ago there wasn't a college of GPs. It was just a default that, you didn't need to pass any exams or jump through any hoops. You could just become a doctor and be a GP after that. However, there is now a lot of skill. There's a high quality required of general practitioners, and a lot of what would be done by specialists can also be done quite competently by GPs, particularly if you're interested in going rural. You could look after unusual conditions to the same level as a specialist would. Granted, it might be harder because you don't have as much experience in that area. You could do skin procedures like biopsies, flaps, that kind of thing that might normally be the domain of plastic surgeons or at least dermatologists. So there's a lot you can do beyond just the coughs and the colds. As I touched on, the training program, the standard program is 3 years, which comprises of 12 months hospital training, another 18 months in general practice placements as a registrar, plus another 6 months extended skills, which is essentially another form of being a GP registrar. But you can do more specific things than just what you normally do as a GP. And one of the great things about general practice is you can either do those first 12 months before you enter the training or once you enter. So it would count essentially as one of your resident years, those 12 hospital months. Having said that, there is the option of a 4th year, particularly if you're interested in rural general practice, which I'll come to. Apologies, this slide doesn't come through that clearly due to the resolution, but this basically can show you progress from where you are right now to where you might want to go and all the steps along the way. And so the postgraduate year 1, PGY1, is the internship, the intern year, and that's mandatory, but after that, the choice is yours. You could go straight into the training program. You could spend the next year or 2 as a resident doing whatever you like, including maybe a PG post, which I'll come to. Then you get through your fellowship, then you might want to do a bit more. You might want to become a rural specialist. You could do further skills, like the academic posts or other things. And so it goes on. As I highlighted, you must do internship before applying, but you don't have to do any more than that. You still have to do a minimum of 2 hospital years, including internship, before you work as a GP registrar. So you're stuck with a lot of the crappiness of residency, even if you know you want to be a GP. When can you apply? From as early as intern year, but you don't have to apply then. You could wait a year, 2, 5, however long you like. Applications usually open in April. So let's say you were an intern this year. You'd be applying in April this year to start as a resident or registrar the following year. The May entries for the rural program. And there's a few general pathways. So there's the main ones through GPET, which is the organisation that oversees training GPs. But there's also a rural pathway through RBTS. Exams. My physician colleague highlighted that you'll be spending however many thousands of dollars on assessments and registration. The good news is, to be part of the College of GP training program, you pay a grand total of $0 per year. However, you probably do want to sign up for the college, because then you get extra exam preparation materials, and that'll set you back a whole $345 as of this year. The exam itself, all three together, costs around $7,000. Now, I'll be working on getting that cost down, but I can't guarantee it for you. However, that's still a lot less than what you'd be paying in other training programs. And the 3 exams, as it says there, there's 2 written and 1 oral. And they can be challenging, but they're fair. You know, you don't have to spend every waking minute that you're not working studying for it. You do have to know a lot. But if you do study hard, you'll get through it. And most people get through it the first time. You do have the option of sitting second, third, fourth. It's no big deal. You don't even have to take a whole year off to resit it. You can resit it 6 months down the track, because they do the exams twice a year. You could choose to do just one of the 2 writtens and then maybe the oral, or you could do both at the same time. You could do 2 writtens 1 year and then the oral the year after if you want. There's a lot of flexibility, like everything in the program. And once you get through all the hoops, and there's not that many hoops compared to the other training programs, you get your fellowship. And what that means is you can practice independently. You can work anywhere in Australia and even some places overseas, so recognised internationally. And you can work in a metropolitan Melbourne, outer metro, rural, whatever you like. You don't have to be supervised from that point. I mean, you get total independence. And that's another significant difference between specialty training and general practice. Because it's important to think about how quickly do I want a good income. And the specialists will get a good income when they're in their 40s and 50s. Because it takes time to build up. It's going to take 6 or 7 years for them to get through the training. But once you finish training, then you need to build up a patient base, which happens slowly. And while you're doing that, you might do some sessions in the hospital system, which doesn't really earn great money. As a GP, you get paid better than your hospital colleagues from when you start the training program. And once you finish, you get paid as well as any other GP, which is a lot better than any registrar gets paid. So something to think about. Do you want a good income from earlier on? Or do you want a really good income, but much later? And then if you want to take it further, you can. If you've got an interest in rural general practice, there's the sort of subspecialty qualification, which is essentially an extra fellowship, an extra year of training, and involves a few specialty posts. And I'm not doing that, so I can't go into all the details, but I'm happy to discuss further after. You can speak to our representative. But this would be down the track. That's once you've done the 3 years and gotten your fellowship at the College of GPs. But there's a lot of opportunities. You can, how far can you go? You know, you can go as far or remote if you want. That's not you have to. And there's lots of opportunities for further specialisation or areas of interest focus. So you could be the kind of GP who wants to see everything. I like the variety. I like that the person who walks in my door, and it's 15-minute or 10-minute consultation, so you get to see a lot of different patients. You know, they could be any system, any age, any type of presentation. It could be acute, chronic. You might have seen them before. You could be tweaking how well they're looked after. Or you could say, you know, I really don't like women's. women's health. I personally don't enjoy obstetrics gynecology. Unfortunately for me, most women are not interested in seeing a male doctor for that kind of stuff. But if you were interested in that, you could set up your clinic around that. Your colleagues, when they get patients with those issues, would refer to you before referring to the specialist who may not provide any additional care beyond what you as the GP, the area of interest would. And the scope of area of interest is really just limited by your imagination. You know, apart from the medical and surgical specialties, there's more might be considered esoteric areas like addiction medicine, refugee health, Aboriginal health is quite popular in the curriculum. You could do that if you want to. So you can really make it as specific to your interest as you want, and you can always change that pretty easily. You don't have to go through another 6 years if you decide, you know what, I don't like skin stuff anymore, I want to do something different. So a few general pieces of advice. One of the things I did was a PG placement, which is where you get to do as a rotation from employment in a public hospital. You get to work for 3 months in a GP setting as a GP registrar would. And I think that's most useful because it's very hard to know what you want or don't want to do until you've tried it. And it's very different perspective as a medical student to when you're working as a doctor to when you have almost full autonomy and you get to practice in whatever way you want to. So I found that very useful to help me decide that's what I want to do. But it might also help you decide, you know, if you continue in general practice but you're not sure, give it a go, maybe you won't like it, well then it's helped you rule that out. As for other choices of what rotations to do in internship and beyond, I should mention that there's only a few prerequisites for GP training, the hospital year and intern year. You have to do an emergency, and the good news is you have to do that anyway for internship. You also have to get paediatric experience. Now, if you are seriously interested in general practice, you probably want to plan your rotations so that you get that in your second year, so that way you could go into being a GP registrar from as early as your third year. But it's useful anyway for a lot of things. And I chose rotations which I felt were areas of weakness for me, because if you're going into a training program or into general practice, the first few years are going to be the only true experience you get with that before going into your area of training. So, for example, I did a cardiology and a respiratory rotation because that's, you know, two of the most common presentations in general practice, so it's very useful for me. And I felt that, you know, I wasn't strong enough beforehand. But even things where I was feeling strong, you know, any additional experience will help you no matter what you do. In particular in general practice, so I don't think you need to rush to get there. You know, I didn't get into the program as soon as I had to. I chose to do an extra year of residency to get a bit more experience to help me choose, do I want to sacrifice my mental health and become a physician, or do I want to enjoy life and be a GP? And you can join as a member, as a student, and talk to your own GP and find out why she or he went into general practice and whether it might suit you. Any questions? Great, I hope that means I answered everything, because other than that, I've turned everyone here off general practice. Thanks for letting me speak.
So just a quick thank you for coming in and speaking, everyone. So everyone, again, a quick round of applause for Paul. Our last speaker from night just got in today. He's come back from a surgical conference in Singapore and got back 7 a.m. this morning. So please give a big round of applause for Dr. Lawrence Lau, who's going to tell us all about surgery and what we're going to expect.
So I'm going to make this quite short. I'm a surgical registrar, and I'm going to sign up for the PG Triple P course next week. Maybe check out a career in general practice. Sounds pretty good. So as you may know, I'm the Austin Health Surgical Supervisor. I'm also a patient attendant. I'm one of the late set trainees, so that's an accredited surgical training course where next year was a final exam. I guess my other qualification for giving this talk is that I'm also married to I'm married to a medical student, and so some of this is advice that I would give some friends, for example. GP. So I was asked to cover the rotations I've done since graduating, a brief overview of the surgical training program, talking about the exams, some research tips, work-life balance, and why I've chosen what I've chosen. So that's what I've done since medical school as a humble international student. So I graduated in 2005 from University. You may realize that that's a long time ago and I'm still training. Doing an internship at RPA. I'll go through all the different rotations. And back then, I would say that the training program was different from how it is now, and it will also change in the next couple of years. So get ready for a training program that is in flux. So back then they had, similar to the physician training, BSc, basic surgical training, followed by advanced surgical training. So I got straight into BSc. So I had my first part exam, and after that, they changed the program. So I got into set training, and because I set my first part, that counted for my set first part. And since I already got through the first exam, I thought, great time to take a gap year. The gap year, best year of my life. I'll talk a little bit more about that later. And after that, I came back and I did 2 more years of surgical training. And you may notice that it's one of those places. This is a different state. And then after that, I decided to do a PhD. And I'll tell you a little bit why I did that and how that's going. So the general surgical training program basically is based on allowing you to acquire surgical knowledge and clinical as well as technical skills and gain sort of experience. It starts, this is lifted off the website just today. It starts with you as a potential applicant. You register your interest to apply, and then you apply. And based on 3 different things, CV, referee, results, and interview, you can get onto the training program. And there's one other thing that's on there, that's not on there, which is starting from 2016 and 2017. So you guys will have to do it if you're interested. You'll need to sit the first part exam before you can apply to get onto surgical training. So it's very competitive. I'm not going to it wasn't when I got on, honestly, but now it is. And it will require at least 6 months of general surgical experience at the level of an unaccredited registrar. So this is a registrar who's not on the actual accredited training program. And you must demonstrate a range of procedural and professional activities. So really, they say that the earliest you can apply is PGY2, PGY3, but more likely you're going to apply for entry in PGY4 or even later. Again, I said you have to pass this first part exam, and that's transitioning in the next few years, so you don't have to do it. And there's the other stuff. So the general surgical science exam, I don't have to talk too much on this. What you want to do, study for your pass. It's based on anatomy, physiology, and pathology. It is hard exam, a very hard exam, particularly when you're working full time and you're trying to get the references, a busy surgical job. Basically, I was doing neurosurg at the time. I would study it from 5 to 6. Go to war round from 6:30, finish at 7:30. I'd study until 10 p.m. That was for about 6 months. So it was somehow I passed and had my year off. The CV, now this is something that if you want to get on the surgical training program, it counts for about 15%. And it's worthwhile
to start optimizing this from your junior years, or even as a medical student. Now all of these need documented evidence, and it's based on surgical medical experience. So if you worked as a surgical registrar, how many terms you worked, these will be points. Other qualifications, so things like masters and PhDs, but realistically it's probably unnecessary to get into general surgery. Courses, different courses. So check out the website there, like leadership courses and courses for a teamwork course. Look, and I think in order for a course to be eligible, it has to be for 7 hours. Again, check the website before you sign up for lots of different things. Publications, this is a big thing. If you want to go into surgery, publications and presentations will in a great way help you get on the other stuff, prizes and awards and teaching. So if you want teaching to count, you need to do medical, surgical, dedicated teaching for 6 months continuous, with a minimum of 2 hours a week. And that has to be documented. The referee reports count for the most, and at the moment it's 60%. Again, all this is in the plus, but referee reports will always be worth a lot. Basically, over a 2-year period, you need to launch a campaign. Right? You have to smile at everyone. There's a lot of us. Be at the right place at the right time. Don't mess up badly. And what happens is you have to provide at least one referee for every training you've done in the last 2 years. I get to a maximum of 3 per term, and 2 of them have to be general surgeons. Okay. When I did it, we had to nominate, nursing unit managers and allied health. It was so things have changed, but who knows, they may change back. Just be nice to everyone. Don't be a douche. So look, you're gonna need referees. I would advise that if you're going to nominate a referee, make sure that they're going to give you an excellent reference. So, be upfront and say, look, I'm going to use an excellent reference. Are you able to give me an excellent reference for this application? And if they pause for a long time for the answer to you, maybe you nominate them. And then remind them of who you are. Also see a lot of interns and junior doctors. And within 1 or 2 years, they may not have exactly who you are in their head. Got a photo on your CV. Not that kind of photo. So the referee reports, what they'll ask the referees is your medical technical expertise, your judgment and clinical decision making, communication, collaboration, your scholar, teacher, Next is a semi-structured interview. This is 25%. This has a little change and stuff. Back then it was, a couple of old surgeons who would ask you, why do you want to be a surgeon? Help you. Stuff. But now it's similar to your medical school interviews where it's an awesome format. There's 5 panels, 2 interviewers each, and you can ask a couple of questions per station. And there'll be a skills station. There's a clinical scenario-based station. So again, this is weighted to help those that have done unaccredited general surgery for years. And also 2 structured non-technical based stations. So my tip is speak to people who have done it before and practice. So all these scores are ranked nationally, and the trains positions are offered based on vacancies. So when I said that they've done the past was BSc, ASC, and now it's set, meaning that you get onto the training program and that's it, you're set. You're set for 5 years. Now what they're going to do, they want to take away the first year, so it's only 4 years of what they've now crammed in to the requirements beforehand, the general surgical experience as well as your exam. So basically, once that's done, the trainees are ranked and allocated based on their state, and all of this is based on the trainee scores. So some of my philosophy is, just chill, relax. Yeah. If you want to get on, persistence usually pays off. I guess that's sort of a biased statement. Because most people don't persist or something else. You may not have paid off. You're unlikely to be the youngest surgeon in the world, so just chill out. Just live the journey. You're also unlikely to retire before you're 70. So say you finish, like you did 4 years, you finish 4 years, about 30 years, doing exactly the same thing, and you might as well pick something that you really enjoy. Anything you decide will be by at least a 1-year campaign. That's not true. It's probably a 2-year campaign. And you should know that no aspect of the entry criteria is just about the need to have training in a particular hub. So those of you who are reading the final year and stressing about, I need to be it's doesn't matter. It just asks for the supervisor report. So if you're one of many fish in a big pond, then your supervisor will be like, well, I have to write 10 different of these things, and all of these is good, best. It makes it hard to get that excellent. Whereas, if you stand out in a small pond, say, Wodonga, maybe you might get a better record report. So that might come play in the game. It's something like that about stressing or which not to get allocated to it. And also, in contrast with the US or Canadian systems, I think we have it really good here in Australia. There's a recognition that it's not about the endpoint. We get paid a lot more. We get recognized for our hours, and we also end up with less debt. And unlike in Canada, where once you decide on a training stream, you can't swap. So say you worked your ass off and you got the ophthalmology, okay? And you figure out that, oh man, I hate eyes. Well, that's too bad. It's either eyes or actually it's like GP, it sounds pretty good. But it's hard to jump into any other field. Whereas in Australia, if you decide to swap from vascular to urology, you say, like, you're not going to do that. Do a bit of research, do your campaign, you don't do urology, it's possible. So again, the 5 years of surgical training, now to the 4, state-based. Once they're on, there are some mandatory courses that you have to complete. And also your surgical training based on local assessments, research requirements, and then you have to pass the Belgian for the Part 2 exam, which is a bit of a monster. I guess a 12-month study, and then I'm studying next year. So. Early career research tips. So for CV points, try to structure your research specific to the specialty you're aiming to apply for. So for Gen Search, I think the requirements is that you can only claim one research that is not within the general surgical specialty. So even, for example, if you've done urology research, right, your second paper won't count. So just be careful. I think these are all policies in flux. This is what happened last year, and I know this was one of my close PhD supervisors is one of the guys who checks through all the CVs. He says, no, Gen Search, this guy definitely wants to do urology. He's using Gen Search as a fallback. 1 point for the 5 papers that he's published. So be careful about that. Start early. I think you guys are in a very good position with the medical selective to get some research and buff up that CV. And really, you need to try to publish that selective. In your earlier years, it's better to do informal or non-degree or informal research. It's better to pitch for clinical retrospective studies. For relevance, that way you're more than likely to get your sort of something else that takes a lot more time than lab-based stuff. I would encourage you to identify a mentor at a consultant level with research interest in the field of interest. And not only will that identify you as a particularly keen student or junior doctor, but that mentor relationship is quite strong. They'll try to keep you tips on how to get onto the program and all that program. So try to identify a mentor. So research, you want to do a PhD at the moment. The pros is lifestyle. You might have noticed that the rotations I did before this was India, my wife being based in Melbourne, and things like that. So research sort of made sure that I was going to be in Melbourne for at least 3 years. Also, it's 8 to 5, no weekends, and there's a bit of a contrast from the surgical trainee or surgical registrar lifestyle. Interest, satisfaction, it also will help shape what my career is going to be like. So once you finish, you realize that life doesn't get any easier, and you make a bit more money or have a bit more responsibility. But all the consultants, they're all stressed about all the things. They're paying the secretary or making patients. And if you shape the way your career is earlier on, say for example in my situation, I want to balance my research with academic with a bit of private and public work. I think that will help. That career shape in the long run. And also, it obviously helps the CV. It wasn't really hard. This is the one I'm doing. It's a big commitment to do that, to do a 3-year PhD. But it does help the CV, particularly if you want to do a subspecialty. So I want to do something to do with liver surgery. And for example, liver transplant surgery, normally before there's only 3 surgeries. So sort of like waiting for this. We want them to retire or listening, that wasn't true. The cons of the PhD, it is 3 years of life. I'm not making a lot of money, but I don't mind. It's alright. I'm used to the student lifestyle. It's a bit more fun. And also that ties the candidate question. So work-life balance, it's a struggle, particularly as a surgical trainee. You notice that with the physician trainee, you get 5 circles, and I've been actually condensed into 3. But I'm not going to lie to you, it's a struggle. And oftentimes you do have to compromise, not only the family and friends, but also yourself. But I would say that it's important to prioritize those things, at least in some aspects of those things. So if you have a birthday coming up, then schedule it in and make sure that you attend, just like you would tutorial or a clinic or whatever. This here's a picture. It's a view of this hospital in Uganda where I worked as a de facto general surgeon after my first year of set training. So this was on the gap year where a lot of traveling with my wife, and we did a bit of volunteer work, fantastic time. Just to remind myself that there's a time where there is a time, and it's important to prioritize lifestyle. So why have I chosen my surgical pathway? It's mainly a mixture of interest as well as choosing pathways for distance. Also, there's a personality match. My surgery, fixed problems, my surgical case, and the technical satisfaction of doing a difficult case or something, making something go smoothly from a technical point of view. I think unlike general practice where you get a lot of variety, it's sort of think of it like skiing. So general practice is sort of like skiing or variety of little bunny hills. Whereas, I really want to nail this, steep morbidly, and I guess do do one thing to its sort of pinnacle, I suppose. Why general surgery, unlike a lot of other subspecialties, it has a wider scope. Cure cancers, fix traumas and sepsis. We do have an overall view of the surgical patient. And like maybe orthopedics, we fix the bone and we've got the geriatrician to take care of. And also transplants, that's one of the main areas that come to the job. That's it. So, view from Uganda. Any questions? I was going to say any questions. Yeah.
And the pathway is the same for international students in terms of allocation and things like that. Are you prepared to be on the same level as Australian applicants, or are you moving more school, or are you moving less?
Yeah, definitely consider less. So I back when I finished in CE, they had this sort of central allocation process where all the students, there's no ranking. You guys are just sort of bigger than the past med school and so and basically we ranked all the hospitals from 1 to 30, and they had this optimizing algorithm where if 2 students chose one hospital, but one of them chose a high, anyways, some algorithm, and they just sort of allocated randomly. And I just sort of like that. I got my first hospital choice. After that, they in my HMO 2 year, they had this regulation that they only hired Australians to do internationals. And even though I ranked very highly, I was in my cohort for medical school, I didn't get offered the first place. And so I was experiencing this. I presented a conference and then one of the bosses said, I said, if they want me, I'll check out Melbourne. So I'll come down and say so. But it is different. It is hard. It's not impossible. It's certainly, I would say don't stress. You don't actually know what the plan is for international training. And I've heard people not take jobs, but in most cases, people do end up taking jobs after that. I should say to getting on this general surgical training nowadays, you do have to be a permanent resident. So that may take a little bit of time to get that qualification and then to apply.
We had one of our web viewers ask is, at the current moment, our entry exams start at the end of residency. Is that the general vibe?
No, so currently you have to get onto surgical training first. And then within your first year, pass this, there's actually 3 exams. There's like a general surgical exam. Then there's a specialty specific exam. And then there's a clinical exam. And if you fail these, then you can't proceed, or you only fail a couple of times. And the problem was that they had all these people failing, not proceeding, and they were on this training program, and because they were on the training program, they needed to have some kind of career progression in place despite failing. So to get around this pickle, this college, as you said, you just have to pass the exam before you even apply.
Any more questions? All right, I think we'll call it a night. So if everyone can give a huge round of applause. I'd just like to quickly thank everyone involved in setting up this night. So I'd like to thank our education subcommittee. I'd like to thank Arms for providing us with money for pizzas and whatnot. I'd like to thank Jane and Ben for doing a lot of the technical work and you got the screen up and the Twitter feed going. Andy for picking up the pizzas and so is Fernanda. Keep an eye on our Facebook page because we've got a lot of fun events coming up. One specifically, which I think you're all going to enjoy. So that's all. I'll leave it there. And everyone, good night. Yes.